All right, so a very good evening, everyone. I welcome you all to this particular YouTube session. So in this session, I will be discussing images related to nephrology, that is part 2. So before starting the session, let me just introduce myself. I am Dr. Rajesh Guba. I am the General Medicine Educator on Arise Medical Academy platform. So I'm just doing a series of the image-based sessions of various chapters and the various topics in general medicine. I have started these sessions almost 10 days back. So those students who did not watch the previous sessions, please go through the previous sessions of the image-based sessions on the various chapters on the general medicine. Okay. So these sessions are very, very important sessions for your upcoming FMGE exam, right? So these are the images which will definitely be asked in your FMGE exam. And in FMGE exam, recently, like we are seeing, almost 70 to 80 questions are the image-based questions. So to see that you should not face any difficulty related to your image-based sessions, we at Arise Medical Academy have come up with this special sessions which are completely free to all the students whoever are appearing for FMG. All right. Next. So let us start with the first question of today. Yes. You see this question here. Acute failure of organ shown in photograph results in hyperkalemic alkalosis, hypokalemic alkalosis, hyperkalemic acidosis, hypokalemic acidosis. So definitely the organ which is being shown to you is the kidney. Now tell me what is that you will have. Very good, Rajkumar. So the answer is C, that is hyperkalemic acidosis. Now in patients with the renal failure, why there will be hyperkalemic acidosis? Remember, in patients with the renal failure, there will be decreased GFR, right? There will be decreased glomerular filtration rate. So there will be decreased excretion of the electrolytes, right? There will be decreased excretion of the electrolytes. And because of this reason, the potassium gets accumulated in the body, and that will make the individual to land up in hyperkalemia. And not only that, in patients with the renal failure, right? Not only that, in patients with renal failure, there is also decreased excretion of H+, right? And due to which there will be acidosis, right? Due to which there will be acidosis. So hyperkalemic acidosis, right? Hyperkalemic acidosis is what you will see in patients with the acute renal failure, right? It is neither hypokalemic alkalosis, it is nor hypokalemic acidosis. It is hyperkalemic acidosis. Now, and not only that, the other reason for the acidosis is due to decreased bicarbonate levels, because in renal failure, bicarbonate is not reabsorbed at the proximal convoluted tubule. Okay, bicarbonate has to be reabsorbed at the level of the PCT, but here the PCT will not reabsorb the bicarbonate, and thereby there will be decreased bicarbonate levels, and that is also one of the reasons why there will be acidosis in these individuals. Now in patients with renal failure, they will not only have the hyperkalemic acidosis, there are many other electrolyte abnormalities that can be seen in patients with the acute renal failure. Now, what are the other electrolyte abnormalities? There can be hypermagnesemia, right? There can be hyperuricemia, right? There can be hyperphosphatemia, right? So there will be increase in the phosphate levels. And potassium, just now I have said, there will be hyperkalemia, and there will be also increase in the H plus ions. But remember, there are certain electrolytes which can be decreased in patients with the renal failure, right? There are certain electrolytes which are decreased in patients with the renal failure. Now, what are those electrolytes which are decreased in patients with the renal failure? There will be decrease in the sodium, right? Why? Because of dilution. Okay, in patients with renal failure, the GFR is reduced. So once the GFR is reduced, there will be fluid overload, right? There will be fluid overload. And because of this particular fluid overload, these individuals, they will have hyponatremia. Okay, so it will be dilutional hyponatremia. Next, right? Very good, Chaudhary. The other important electrolyte that will be reduced, it is your calcium. There will be also hypocalcemia. Now the question is, why there will be hypocalcemia? Why? Because this particular calcium which is available in our body, it will form a precipitate with the phosphate, right? It will form a precipitate with the phosphate, and that will result in calcium phosphate, and due to which the calcium levels, the ionic calcium levels, they are reduced. So these are the electrolyte abnormalities what you will see in acute renal failure. Right, these are the electrolyte abnormalities that you will see in patients with the acute renal failure. Okay, right. So this is about the first question, that is acute failure of the organ shown in the photograph. It results in hyperkalemic acidosis, right? Results in hyperkalemic acidosis, right? Next, then followed by that, you see the next question. Yeah, now I will just discuss in detail about all the renal stones, but before that, you answer this question. True about struoid type of stones shown is present in alkaline urine, most common kidney stone, composed of the calcium pyrophosphate, present in acid medium or present in acid urine. Yes, any one of you please. True about struoid type of stones shown here. Right, very good Rajkumar, excellent. Okay, so the answer is this struoid type of stones, they are present in the alkaline medium. I will explain you. Right, they are present in alkaline medium. Now let me explain you about the urolithiasis. Right, let me explain you about urolithiasis. So if you take the renal stones, these are all the various types of renal stones. Okay, one is your calcium oxalate stones, calcium phosphate stones, then triple phosphate stones, then we have urate stones, and next we have cysteine stones. Now what is the question asked to you? The question asked you is the struoid stones. Now can anyone tell me which among the following is your struoid stones? right? Which among the following stones is your steroid stones? Any one of you, please. And remember, among all the various types of the renal stones, that is urolithiasis, the most common is your calcium oxalate stones, right? Most common is your calcium oxalate stones, right? Very good, Tejendra Verma. So your steroid stones, they are nothing but your triple phosphate stones. Your steroid stones, they are nothing but your triple phosphate stones. Now, let me explain you about this triple phosphate stones or steroid stones. So this triple phosphate stones or steroid stones, remember, they are formed in the alkaline medium. This is a true statement, right? It is formed in the alkaline medium. It is a true statement. Now, let me explain you in detail about this particular steroid stones or the triple phosphate stones. Okay. Why am I using the word triple phosphate? Right? Why am I using the word triple phosphate? Because it has magnesium, ammonium, and phosphate within the stones. Right? Magnesium, ammonium, and then phosphate. Okay. And as already just now I have discussed, they are the one which are formed in the alkaline urine. They are the one which are formed in the alkaline urine. Now, how is this particular alkalinity created? Right? How is this particular alkalinity created within the for the formation of the triple phosphate stones? We have an important organism, that is the Proteus mirabilis. It is a urease positive organism. Right? What it will do? It is a urease positive. That means it will split the urea into ammonia. Right? It will split the urea into ammonia. And this will cause the precipitation of magnesium ammonium phosphate stones. This will cause the precipitation of magnesium ammonium phosphate stones. Now, can anyone tell me how should I treat these particular stones? What will be urine examination picture in these triple phosphate stones? Yeah, anyone please? How should I treat these triple phosphate stones? And what will be the urine examination picture in patients with the triple phosphate stones? Anyone? No, Rajkumar, directly you want to do PCNL and ESWL? Huh? Right. So, what should be the urine examination finding? See, urine examination finding in these patients with the triple phosphate stones, it will show what is called coffin lid appearance. Right? So, this is nothing but your coffin lid appearance. Right? This is nothing but your coffin lid appearance. All right. Now, that is what the urine examination showed. And these stones, the triple phosphate stones, if the size is big, right? If the size is big, they can appear as what is called as steroid stones, or it is also called Staghorn calculus. Right? It is nothing but the Staghorn calculus. Yeah, yes, Rajkumar, that is what I am showing you. They usually they are of big size, right? You see, this big is your triple phosphate stones, that is magnesium ammonium phosphate stones. Okay, then how should you treat this? Right? How do you treat? The treatment is you need to give antibiotics or irrigation of the kidney. Right? And how do you irrigate the kidney? that is with the help of a substance called acetohydroxamic acid. Now, what does this acetohydroxamic acid will do? Acetohydroxamic acid will remove the protease mirabilis. Right, will remove the protease mirabilis. That is what is your acetohydroxamic acid, right, where you will give the antibiotics or irrigation of the kidney parenchyma with acetohydroxamic acid. Okay, right. So that was about your magnesium ammonium phosphate stones or the triple phosphate stones. And what are the most common stones I have taught you just now? The most common ones are the calcium oxalate stones. Now, what is the cause for this particular calcium stones? Calcium stones, they are seen in almost 80% of individuals. So, we have calcium oxalate stones, calcium phosphate stones, triple phosphate stones, cysteine stones, and uric acid stones. We have finished one stone, that is the triple phosphate stone or magnesium ammonium phosphate stone. Now we are discussing the second type, that is calcium oxalate stone. Okay. Now these calcium stones, they mainly occur due to idiopathic hypercalciuria. So within the urine, if more amount of calcium is passing through, that is what is responsible for the calcium oxalate stones. So even if you check the 24-hour urine calcium, even if you see the 24-hour urine calcium, that will be increased, right? That will be increased. Now, can anyone tell me what is the etiology of this calcium oxalate stones? What is the etiology of this calcium oxalate stones? And how do you treat these particular calcium oxalate stones? Medical management, right? Medical management. What is the drug you will give for the treatment of this calcium oxalate stones? Any one of you? And what is the etiology of this particular calcium oxalate stones? Very good, Rizwana. So the cause for that particular calcium oxalate stones, it is definitely hyperparathyroidism. Excellent. Right, hyperparathyroidism. Can anyone tell me what will be the urine examination finding in these individuals? Yes, any one of you? Urine examination finding in these patients. Urine examination finding in these individuals, you will have what is called envelope shaped crystals. You see, these are your envelope shaped crystals. Right? See, in case of triple phosphate stones or magnesium ammonium phosphate stones, what is the urine examination finding we have seen? That is the coffin lid appearance. But what is the urine examination finding in patients with the calcium stones? That is envelope shaped crystals. Then how do you treat these patients? Right? How do you treat these patients? So the treatment is by giving thiazide diuretics. The treatment is by giving thiazide diuretics. What this thiazide diuretics will do? Thiazide diuretics will decrease the urinary excretion of calcium. But at the same time, remember, please don't give loop diuretics. Right? Don't give loop diuretics. Now the question is why? Now the question is why? Why? Because this particular loop diuretics, right? This particular loop diuretics, what they will do is, furosemide is a loop diuretic. It increases the urinary calcium excretion. It increases the urinary calcium excretion. So that is the reason why this furosemide will further precipitate. Furosemide will further precipitate this particular the calcium stones. So that is the reason why don't give furosemide, but you can give the thiazide diuretics. That is very important. Okay. Next, So that was the story of the calcium stones or calcium oxalate stones. So calcium oxalate stones, what will be the appearance of the calcium oxalate stones? That is your envelope shaped crystals. That is your envelope shaped crystals. And you have calcium phosphate stones also, right? Now please, can anyone tell me what is the etiology of this calcium phosphate stones? See, this is another image based question related to your renal calculi. In calcium phosphate stones, remember, it is rosette shaped crystals, right? It is rosette shaped crystals in the urine. Now can anyone tell me what is the etiology of this calcium phosphate stones? Etiology of the calcium phosphate stones. Right, so yes, so that is in case of hyperparathyroidism. In case of hyperparathyroidism, where you will see this rosette shaped crystals in the urine, right? Good. Next, and in case of the oxalate, right, we have what is called calcium oxalate crystals, right? So why there will be hyperoxaluria, right? Why there will be hyperoxaluria? Hyperoxaluria you will have in clinical scenarios like celiac spoo or the intestinal resection, where there is intestinal malabsorption of the oxalate. Where there is intestinal malabsorption of the oxalate. That is about your oxalate stones. Next. Now, if the question is asked, right, see, this is a very, very important question. Which is the softest stone among all your renal calculi? The softest stone is your urate stones. Because it is softest, there is no particular shape also. There is no particular shape also. And where do you have these urate stones? You will have this in case of the chronic gout. Right? You will have this in case of the chronic gout. So this is what is your urate stones. This is what is your urate stones. Okay, right. Next, then followed by that. And in case of the urate stones, if you check the 24-hour urinary uric acid levels, they are elevated. Right, 24-hour urinary uric acid levels are elevated. Okay, and the treatment is allopurinol or the probenecid. Right, probenecid. So allopurinol, what it will do? It will decrease the uric acid production. And probenecid, it will decrease the uric acid excretion. Yeah, sorry. Right, it is associated with the probenecid. It is, yeah, it will decrease the uric acid excretion. So that is what is your uric acid stones. That is what is your uric acid stones. Okay, right. So uric acid stones are the softest stones. And if the question is asked, which is the hardest stones? That is your cystine stones. And these are hexagonal crystals. These are the hexagonal crystals. Okay, so this is about your urolithiasis. So to summarize urolithiasis in 2-3 points, among all the stones, remember the most common stones, they are your calcium oxalate stones, right? The more common one are the calcium oxalate stones. Now, yes, and the triple phosphate stones are the one which are formed in the alkaline medium, right? And the organism is Proteus mirabilis. Okay, either you give antibiotic or you irrigate the renal parenchyma. And urate stones, these are the softest stones. right? And the cystine stones, these are the hardest stones, right? So this is the summary of this particular renal calculi. Summary of the renal calculi. And you should know urine examination, where you will have coffin lid appearance, where you will have, okay, I'll just shortly revise. So which particular stones, the urine examination shows the coffin lid appearance. Which stones, urine examination, you have the coffin lid appearance. Which stones, you have envelope shaped stones. Which stones, you have the rosette shaped. Urine examination. And which particular stones, hexagonal shape. Yes, coffin lid first. Right. So that is your triple phosphate stones. Yeah. What about envelope? What about envelope? Right. Very good. That is calcium oxalate stones. What about rosette shaped? Very good. So that is your calcium phosphate stones. Right. Which are your hexagonal shaped? Which are your hexagonal shaped? Right. Yes. So the hexagonal shape are the cystine stones. Right, hexagonal are cystine stones. Okay, so that completes the discussion of the renal calculi and their shapes, okay, and their images. Everything about the renal calculi in a nutshell. Next, now I'll just show you one last image and we will wind up this session. Okay. Right, so yeah, you see this is a cast. This is a cast. Okay, whatever I am showing you in the box, this is a cast. Cast shown in the photograph are usually found in acute tubular necrosis, right? Interstitial nephritis, nephritic syndrome, nephrotic syndrome. In which clinical scenario or which pathological condition of the kidney you will have this particular cast? Yeah, Jitendra, it is just only half an hour session. Right, very good, excellent. So what is this? This is an RBC cast. Right, this is an RBC cast. So where do you have this RBC cast? It is seen in patients with the nephritic syndrome. So in nephritic syndrome, the clinical feature is the cola colored urine, okay, and urine examination shows RBC or RBC cast. And the urine examination will also show the presence of the proteins. There will be also a significant proteinuria, and proteinuria in nephritic syndrome is 3 grams per 24 hours. Right, it is 3 grams per 24 hours. Okay, so that is about the story of your nephritic syndrome. So the cast which is shown is RBC cast. So if the cast is formed, that means where should be the pathology? The pathology should be always in the kidney, not in the ureter, not in the bladder. The pathology should be always in the kidney. Okay, so that is about your nephritic syndrome. Acute tubular necrosis and interstitial nephritis, the first two options, they will lead to acute renal failure. And in nephrotic syndrome, hematuria is less common. I don't say that hematuria is not there in nephrotic syndrome. In certain etiologies of nephrotic syndrome, you can have hematuria also. But it is less common compared to that of the nephritic syndrome. Compared to that of your nephritic syndrome. Okay, so with this, I will wind up the session on image-based questions on nephrology. And from tomorrow onwards, we will discuss images on the cardiology, right? So images on cardiology also are very, very important in your upcoming FMGE exam. So please follow me daily at 10:30 on Arise Medical Academy platform, where I will be discussing images every day. And those students who did not watch the previous sessions, please watch the previous sessions also, which are available to you in a recorded format, right? So those are the sessions which will definitely will be helpful for your upcoming FMG exam, right? So thank you very much. Good night and see you tomorrow at 10:30. Yes, Raja. I will send this particular PPT on the Telegram channel. Okay, right.